Find out about the latest developments in the psychiatric treatment of mental illness and get your questions answered about medications and other psychiatric treatments for mental illness. We're talking about medications, mental illness, and what's new in psychiatry next on Speak Your Mind. Welcome to Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with the Human Development Center. While therapy alone can be helpful for some people with mental health problems, for those with certain types of mental illness, psychiatric interventions such as medications or ECT, also better known perhaps to you as shock therapy, may also be indicated. Tonight, we'll hear about what's new in psychiatry, and we'll also talk about, well, those things that have been around for a while. That's helpful. So if you have questions about medications and mental illness or other psychiatric interventions, call locally. Dial 218-788-2844 or call toll-free at 1-877-307-8762. We'll be answering your questions throughout tonight's show. Joining me is Dr. Steve Bauer, the medical director at the Human Development Center. He's board certified in child, adolescent, and adult psychiatry. And Dr. Steve Sutherland is the chair of psychiatry at Essentia Health and the medical director of Amberwing Center for Youth and Family Well-Being. That's a mouthful. He's board certified also in child, adolescent, and adult psychiatry. Thanks to both of you for coming out tonight. And I think where I'd like to start, because we don't talk often enough about these things, are what's known as the brain stimulation interventions. And one that is been around for quite a while, Dr. Sutherland, is electroconvulsive therapy, also known as ECT, and maybe the general lay public, who I think they associate that most with, unfortunately, the scenes from One Flew Over the Cuckoo's Nest when shock therapy. So let's do a little education about ECT.
Well, ECT is decades old, and in the era before the 1950s, before the first psychiatric medication was invented, and therefore there was psychotherapy and there weren't any other, say, biological therapies. Astute observers noticed that people who were ill, most especially with depression, who also had epilepsy and had a seizure, would have a significant brightening of their mood often. And so that led to further studies, and eventually the process of electroconvulsive therapy, where a seizure was intentionally started through an electrical pulse to the brain, began to be a studied and then proven treatment. And so the history is very, very long. People, with the advent of all of the medication therapies, especially in the last 30 years, when there's been, it seems like a new one every month, people forget about some of the older treatments. But for some people that unfortunately have fairly severe illness that is not responsive to psychotherapy, medications, and are very, very disabled, it's a very effective treatment, and in fact has alleviated a lot of suffering.
And can be life-saving then for people
Correct.
as well who are at real high risk for suicide.
That's correct.
I think that, that scene from One Flew Over the Cuckoo's Nest is very disturbing, and so tell us a little bit right now, how is ECT different from maybe back when it was started?
Well, it's a great point, because I think ECT is done under anesthesia, which the Cuckoo's Nest movie was not very subtle that way. And under anesthesia, a single sided pulse, or what we call unilateral, is now proven to have less cognitive disturbance, and the only other mild side effects that we typically see when people undergo this treatment. So it's also being used in more specialized areas. The folks with Parkinson's who have depression have found ECT helpful for both Parkinson's and their depression, as well as severe psychosis. So the current version of ECT is a very small procedure that takes a short period of time, and most people tolerate quite well.
And I think that, so tolerate quite well, let's talk a little bit about that notion of tolerate quite well, because I think that some of the myths surrounding that is that there's severe memory loss is associated with ECT, or people kind of turn into these zombies and they're not themselves, so maybe they're living, but they're not living.
Right. It very much compares to people that have epilepsy, that have seizures. And during the process of any anesthesia, there's light anesthesia given before the ECT, as Dr. Bauer said, and then following the seizure, following the procedure, and typically the seizure lasts from anywhere from 60 to 120 seconds, there can be a period of confusion, taking a while for the brain to wake back up. Generally speaking, that occurs within minutes. Within 2 hours, the person typically is back to feeling very much like their usual thought processing. There can be, during the process of looking back at a course of ECT treatments, a person can have a general fuzziness for some of the elements of the time immediately surrounding the treatments. But in terms of, is there a permanent memory loss? No.
And we had a guest on the show, and if some of you are old-time viewers and have been multi-season viewers, you will remember a guest on our show, Ms. Rena Carey, who talked about having ECT treatment and how that really transformed her life. And I think that that's really important for all of you to hear as well, that it shouldn't be looked upon as a scary intervention, but rather something that can transform people's lives and give them back their meaning and purpose for living then.
Been witness to it many times, so it is a very good and effective treatment.
Deep brain stimulation, the second. We're going to be talking about 3 of these brain stimulating interventions. So deep brain stimulation.
So deep brain stimulation actually involves surgery, which is a little more invasive kind of situation, and tries to do what most folks refer to as neuromodulation, by stimulating certain areas of the brain to slow the overexcitement in some cases. So the long and the short, it was very effective. Again, Parkinson's is an area that has a lot of overlap between mental health and neurological symptoms, and deep brain stimulation has been proven quite well for that. It remains a much more risky kind of procedure, and should be kind of down the chain when we talk about decisions for folks. But when their debilitation is such and nothing else has helped, it certainly continues to be brought up. I don't think that the procedure is done locally, unless Dr. Sutherland knows of anyone at Essentia that's doing that kind of. But it is available in the state, I believe.
It's they're university-based research centers that have research protocols, and typically it's people with severe obsessive compulsive disorder who essentially, if you can think, again, the comparison to Parkinson's, if you can think of somebody whose tremor and body muscle changes have become so severe that it's constantly debilitating. And then if you can picture somebody whose obsessive compulsive disorder has really consumed their life, and you can almost picture the loops of thinking and emotion in their brain, the stimulation, the pulses that get sent to that area of the brain that's precisely located by the surgeon can disrupt that and give the person moments or even hours of freedom that from some of the most severe symptoms they wouldn't have otherwise had.
And some of the reading that I did, and I don't know if this is currently FDA approved in the United States, or if they're still, some of the reading I did said that some of the people with just the severe debilitating OCT, they get the humanitarian device exemption because it's not FDA approved. Now, I might have done reading that was a little bit too old in that.
No, you're correct. It's done all within research protocols at research institutions.
Yep. And I know it's being done at the Mayo Clinic, so if anybody's interested in more research on that, you can go to the Mayo Clinic website and look that up. Here's a mouthful. I had to work on just memorizing this one. Repetitive transcranial magnetic stimulation. Dr. Bauer.
Yeah, so this is a milder procedure that was FDA approved in 2008, using something that can be office-based and doesn't have to be done under anesthesia.
So it's not invasive.
Non-invasive, and doesn't require even anesthesia level of risk, which anytime we do anesthesia, there is a risk to the patient. So it has been widely talked about, and my understanding is there may be a machine here locally soon, but so far most of the studies talk about it being mildly helpful for the milder versions of mainly depression. I have not seen much good evidence to say that it helps with more severe psychosis or those kinds of things.
Okay, we're going to go to a question here, and this is back now. Now we're going to a medication question here. So more mainstream psychiatry question. A woman in Duluth is asking, for a person on antipsychotics that causes legs cramp, can you do anything for drug side effects? So, which I think is important, like this whole concept of that we know that there's some psychiatric medications that cause side effects, and then what do we do to help people with that?
Right, this is a good example of where we know enough about the science to be able to map out a little bit about how this happens. So for instance, part of the way that antipsychotic medications work, the way that they block hallucinations and other psychotic symptoms is that they block some of the dopamine circuits that produce some of those symptoms. But the problem is, of course, is that dopamine circuits are located in other parts of the body as well, besides those that we associate with hallucinations. And so what can happen is you can get muscle stiffness or cramping, you can get muscle shakiness as well. And yes, there are antidote medications. To name a few of them, things like cogentin or benztropine or propranolol is sometimes used. Artane, there's a number of medications that can be used as antidotes that help mediate those side effects.
So that people who are having a really good response to their antipsychotic, then they don't have to worry about going off of it just because they're having side effects, and that we can treat the side effects often just as well as we can treat the disorder, and so you're not having to make difficult life decisions in that way.
Absolutely, and certainly dose can affect that, and quite often when people are first being diagnosed and having problems, we'll use a dose that sometimes might be mildly reduced later in the course of treatment if those symptoms are becoming problematic.
One of the other issues that I see a lot, and I also hear from the patients that we see, are how many medications is too many medications. So, and I think that can go in two ways. One is just sort of the total number of medications that you're taking, whether you're taking some medications for physical health problems and some for mental health problems. But also, let's start first with just this notion, Dr. Sutherland, I'll go to you first, of how many psychiatric medications is too many, because I've seen people who've come on and they're on an antipsychotic and they're on a mood stabilizer and they're on an antidepressant and an anti-anxiety and maybe a couple of others to boot. So,
well, I suppose to start with, the answer to the question of how many is too many is one more than you need. And so I have certainly met people with different mental illnesses ranging from, say, depression to schizophrenia to bipolar disorder to post-traumatic stress disorder, who have needed every single one of the 4 medications that they need. I've also seen people that are on 4 medications when they really only needed 1. And typically the best place to start on that is from the beginning. And if the person taking the medications and their healthcare practitioner can be very parsimonious about how they do this and make sure they've given a single medicine not too much time to work, but the right amount of time to work, and then adjust things one at a time. And if something, frankly, is not deserving of being kept around, then even it's been very mildly helpful, the best thing to do is probably to discontinue that one, get rid of it while you're starting the next one, and that way you don't pile on from the beginning. Once you get these this extended number of medications, which sometimes is necessary, it's hard but not impossible to peel back. And so we spend a lot of time with people sometimes trying to peel back some of the multiple medications they're on, but we have to do it cautiously, of course, because we don't want to make them worse.
And I think that there sometimes gets to be even then almost a psychological dependence too that makes it difficult to peel back, right? If you think that these medications are helping, and if your mindset is the problem is just that I need more, then the suggestion that we need to sort of peel things back and see what things are like afterwards. And people don't want to go, it's hard to tell people like, let's go back, because that can sound like, and have me go backwards. Mm-hmm. And there's a lot of being patient required of, of all of us who are engaging in with the healthcare system, but including the mental health care system as well.
Well, I think that's an excellent point. It really depends on diagnosis and kind of the individual patient's pattern of presentation. So, with major depression, we consider that to be an episodic illness, and most of the research says if you've only had a single episode of major depression, we would ask that, after 6 months of doing well, that we could consider taking off the medication. But as you talk about, a lot of times patients really associate their recovery with the medicine and become more likely to say, well, I'm more comfortable staying on the medicine. And there's certainly more information saying that that's not a necessarily bad thing. I think the other thing that goes to this, how many medicines, quite often we have, with all the new medicines that have come out, become much more selective in the kind of approach that we use with medicine. And sometimes we start with the less invasive kinds of medicines, and those are very selective, and we can be more selective by using more medicines as opposed to using one broader medicine that has more side effects.
And so one of the things we're sitting here talking about medications that dawned on me is sort of maybe is newer in the field, and we said that we would talk about new things in psychiatry, is genetic testing, especially taking a look at the metabolism of medications. And talk a little bit about that. And do you see that as something that's useful? How do you see that as being useful?
Well, there's good news, bad news on that one. It's the good news is that we have genetic testing available that can help reduce the odds of the medicine that a person taking the medicine and their practitioner chooses being one that their body doesn't do well with. It doesn't metabolize it well. And so sometimes when the testing is done, you can bypass what would have otherwise been a highly side effect laden trial. The bad news is that's about the best news. The genetic testing that's available does not at all guide us to which medicine is that person going to respond to. That's still looking at family history, looking at traits of that particular patient, and some educated guessing ends up being the best, anyone's best guess about which is going to be the most effective medicine. So the genetic testing is really limited to trying to test which medicines might be more side effect laden for that person.
And so maybe 10 years from now or 5 years from now, we'll have better information than about that. Talk a little bit about just even, I think that there was a period of time where, and certainly back when we were during the time where if people had pre-existing conditions, that they could have problems getting insurance coverage. And then with the Affordable Care Act, we got right with healthcare for a while, and so now we have more genetic testing available, including in the field of mental illness and in the field of psychiatry. And with the current climate, any concerns about what this means about people making good informed decisions with respect to genetic testing then?
Well, I think this is one of those topics that everyone's hopeful for new information that will make better decisions. As Dr. Sutherland pointed out, currently the genetic testing really focuses on the liver and how your liver might be different than other people's as to how rapidly it metabolizes medicines. And we have a pretty good idea which of those medicines are affected by which of these tests, which there's only a couple of them available right now. And so utility-wise, the insurance companies are still not always excited to pay for this, even when we had the Affordable Care Act. And with the news suggesting that the Affordable Care Act will be repealed, it will be difficult to say what that will mean, but I do think there will need to be more kind of ongoing oversight to help make sure that folks can get what they need when they need it.
Excellent. A woman calling in from the Iron Range wants to know, Dr. Sutherland, thoughts on injectable ketamine as a viable treatment for depression.
Oh, you just hit on a good question. That hits upon a part of the neuromodulation, as it's called, or that field of interventions that affect the brain in some way other than medications do or psychotherapy does. So neuromodulation. So ketamine is an example of a medication that's often used in the world of anesthesia. It alters a person's pain threshold and alters their mental state as well. There's actually a point at which ketamine acts on some of the brain receptors in the glutamate system that are similar to those in some of the hallucinogenic drugs that people may have heard of in the past.
Some people are using that recreationally for that reason as well.
Precisely.
Yep.
But it's been shown to provide, in some treatment-resistant depression situations, it's been shown to provide an antidepressant benefit that's above and beyond any other medication the person has tried. It can be very effective. The good news, bad news there. The good news is it can be quite effective. The bad news is all of the studies worldwide, and there are studies going on worldwide in this, suggest that each individual treatment at best tends to last a period of a few weeks. And so there's a need for repetitive injections, for instance, of the medication.
Here's another caller from Superior. Dr. Bauer, can antidepressants or antipsychotic medications increase the risk of Alzheimer's?
Very good question. Certainly the research in Alzheimer's and the research around medications have some overlap that way. Some of the antipsychotics in particular have been really restricted in elderly folks, partly due to some concerns that way. To say there's a definitive connection, we're seeing that Alzheimer's is really quite closely linked to genetic risk factors and not so much in what medicines you do or don't take, though there have been lots of connections along the way. I can remember when aluminum cans were somehow linked with Alzheimer's at one point. But so there have been some studies that have suggestion, but nothing definitive that way.
The prescribing medications at the extremes, and we're on the verge of being short of time here. So let's just talk about medications and kids. And so now the question is, how young is too young?
Well, it depends on the condition, for one thing. I think that how young is too young is a relative question. There's not an absolute answer to that. And I'll give you an example that, for instance, in some conditions, let's say autism would be an example. Fetal alcohol syndrome would be another one, where you've got a known, at least a partially known neurologic syndrome that's happening that results in a disturbance of emotions and behaviors. If you've got a person with such severe symptoms that just their ability to have a quality of life at home, in school, in the community, et cetera, is impacted enough, we would consider something like medications, whether they be medications that are stimulant medications or neuroleptic medications, considered at a younger age than we otherwise would if it weren't for that threat to the person's livelihood. Typically speaking, the younger the person is, the more we emphasize psychotherapy first. And once you hit adolescence, that rule still applies. We still emphasize that psychotherapy is the least invasive treatment and should almost always be used. But we also have good studies that show that medications, when you add a medication to psychotherapy, it increases the odds of a moderate to excellent response for the depression or the anxiety. And so you start, the closer the person gets into adolescence and then beyond, the more evidence there is that medications can actually improve a person's odds of improvement. And so the conversations start to get a little bit more realistic at that point.
And so really what we're talking about here a lot of the times is taking a look at the relative risks and benefits, which is what we when it comes to any kind of medical intervention, is what we ought to be doing in terms of making informed decisions both for ourselves and for our children then. And in these very extreme cases, what you're saying is that although we wouldn't normally prescribe medications at this age for a child who is otherwise very healthy and able to lead a relatively quote-unquote normal life, there are some children whose disease states are so debilitating that to not have that option available for them is more of the doing harm.
Correct.
So
That's
I think we are just about out of time. I love having the Dr. Steves on the show because they're a great tag team, and I'm not disrupting this tag team. They'll be on next year as well. So take-home message, quality of life can be improved by a number of mental health interventions, including psychiatric interventions, and those not necessarily all that well known. Thanks so much for joining the discussion tonight, and don't forget to visit us on the web at speakyourmindonline.org, where you can find a schedule of our topics and resource links. Speak Your Mind will be off the air for the next 2 weeks as we celebrate Thanksgiving, and WDSC has its annual membership drive the following week. My moment of Thanksgiving gratitude with you is to be grateful that we live in a community that has supported the mission of this show by tuning in and being a part of reducing the stigma surrounding mental illness by taking the conversations we have here into your own circles of community. Have a good 2 weeks and come back and join us on Thursday, December 8th for our next program, when we'll be talking about complicated and traumatic grief. I'm bringing a notebook and a pen for that one. I'm Dr. Carolyn Phelps. Thanks for watching and good night.